So good afternoon, everyone. I wanted to take time to thank everyone for coming out, and we'll give a few minutes just to let people continue to log on and join. I know that there's some time zone differences in a few areas, so we'll just give a few minutes and then we'll jump right back in. Give it about another minute or so, and we will start the show. All right. To make sure that we are keeping up with time and everything, we're going to jump right into our webinar. So again, I wanted to take time to thank everyone for coming out and joining the webinar today. Just so everyone knows, for the duration of the webinar, with the exception of the panelists, your mics will be muted. And this webinar is being recorded. So following the webinar, it will be uploaded to our NASTAD Drug User Health page. And if anyone needs the link or anything for that, feel free to reach out to me via email and I can send that over to you. So diving right in. So a brief history and little background about NASTAD. So NASTAD is a nonprofit, nonpartisan national association that was founded in 1992. Represents public health officials who administer HIV and hepatitis programs and is funded by state and federal dollars. Currently, NASTAD has locations in all 50 states, District of Columbia, Puerto Rico, the U.S. Virgin Islands, 7 local jurisdictions that receive direct funding from the Center for Disease Control and Prevention and the U.S. Pacific Island jurisdictions. As a mission, NASTAD's mission is to end the intersecting epidemics of HIV, viral hepatitis, and related conditions by strengthening domestic and global governmental public health through advocacy, capacity building, and social justice. In the pursuit of our vision, which is to see a world free of HIV and viral hepatitis. So we also wanted to lay out the goals and objectives of today's webinar. So our primary goal is to increase awareness of the intersection of trauma and drug use and really highlight the importance of utilizing or incorporating a trauma-informed approach for people who use drugs. And the objectives that we're looking to address today and accomplish are provide an overview of trauma and its impact on the neurological and childhood development of individuals, provide data/research on trauma and its impact on drug use, misuse, and overdose, provide information on and examples of the trauma-informed care approaches, raise awareness of the importance of developing resilience factors, and lastly, providing examples of developing or strengthening resilience factors within people who use drugs. Okay, so our agenda for today's webinar, we have already had our welcome, but just in case you're just jumping on, welcome again. Thank you for coming out. So we're going to start off with an overview of trauma before leading into the impact that it can have on people who use drugs. Following that, we'll be unpacking what it means to take a trauma-informed care approach and the importance of resiliency. We'll then look at some examples of trauma-informed care approaches in practice. And here today to provide some of those examples, we have 2 of our guest speakers / panelists, Timothy Shelton from a behavioral health consultant at the Appalachian Mountain Community Health Center in North Carolina, Western North Carolina, and Margaret Bordeaux, who works as the Justice-Involved Overdose Prevention Specialist at the North Carolina Department of Health and Human Services. Following that, we'll have a Q&A session for folks on the call, and for any questions that you have, we ask that you place them in the chat box, and during the Q&A session, we'll be sure to get to as many questions as we can. Finally, we'll have some resources that we'll make available to you. If you're interested in obtaining the resources that are going to be on the final slide of the presentation, be sure to email me following the webinar, and I can send those over to you. All right, and with that being said, I'm going to hand it over to Mahalit, who will jump into the overview of trauma.
Thanks so much, Virgil. You can go ahead and thank you. Advance to the next slide. All right. Well, good afternoon or good morning, depending on what time zone you are joining us from. My name is Mahalit Kabeta, and I serve as a senior manager on the healthcare access team here at NASTAD. Very excited to be here with you all today and share a little bit more of the sort of theory and science behind trauma and leaving a lot of the practice and implementation piece to our 2 guest speakers. Before I jump into content, I do want to provide a little bit of a blanketed trigger warning. This webinar, as you all know, is regarding trauma. Trauma in and of itself, just hearing that word, discussing it at length, talking through practices, or excuse me, not practices or examples of trauma can be triggering to folks. So I want to encourage you all to step away as you need and as you see fit. We'll also do our best to provide specific trigger warnings when something that we're about to discuss goes a little bit more into detail. So we can go ahead to the next slide, Virgil.
All right.
All right, so what is trauma? So really just laying the foundation here. You know, there are many definitions of trauma that are floating around. We do not feel like anyone is more right than the others. What you're seeing on your screen is just the definition of trauma that we at NASTAD have adopted. Now, being trauma informed, or that term trauma informed, that's really what we want your agencies, your programs, or your health departments to be or to strive for. And trauma-informed is really about an approach to administering services, acknowledging that traumas are either occurring in and are active or have in the past occurred in our clients' lives, and that they can manifest in different ways that we need to be cognizant of as we work with our populations. And then finally, TIC versus TIA. So those are two acronyms, obviously. TIC is trauma-informed care, and that is probably the term that you have heard most often versus trauma-informed approaches. And trauma-informed care is really one type of trauma-informed approach. And what you will hear us talking about a little bit more at length at NASTAD is trauma-informed approaches, and that is for two reasons. Number one, our membership is health departments, and oftentimes our health departments are not providing direct care to clients. They're working through community-based organizations, they're working through SSPs, they're working through aid service organizations, etc. And so that's why we talk about approaches more often than care. And approaches really is all-encompassing. There are ways for your agencies or your health departments to be trauma-informed through the policies you have, through the structures, the administrative structures within your organization, through the actual environment, right, and the physical layout of your agencies. And so we want to just encourage and sort of direct and push folks to think about all of the approaches. And so that's what you'll hear me referring to more often. Now, as far as care goes, we're going to hear some actual examples from clinicians later on today who actually work in those spaces, you know, where there's a direct relationship between a provider or a clinician and a client. Next slide, please. So talking a little bit more about the theoretical basis for trauma. I don't know if many of you have heard of the term neuroscience before. Researchers are developing a more comprehensive understanding of trauma, including through the concept of neuroscience. And NEUR is actually an acronym. The N is for neurobiology, E is for epigenetics, A is for adverse childhood experiences, or ACEs, as you may know them more so as, and then the R is for resilience. And neuroscience really just provides a holistic understanding of how trauma impacts health outcomes. And so we're going to talk through each of those right now. So let's start with the N in NEUR, which is neurobiology. So that, of course, has to do with the brain. And we're just going to focus on the three parts of the brain that are most pertinent to trauma for the purposes of our conversation today. So I'm going to start with the prefrontal cortex, which is the part of your brain that's right behind the forehead. The prefrontal cortex is also known as the thinking center. When this part of the brain is strong, we are able to think clearly, we're able to make good decisions and be aware of ourselves and of others. Research indicates, however, that after trauma, particularly trauma during childhood, the prefrontal cortex experiences a loss of neuronal integrity and is less able to communicate with other parts of the brain. Neuronal integrity that's a little bit of a jargony way of saying that it's just not functioning at its optimal level. And that's going to be really important to note, and I will kind of draw us back or circle us back to that point, and why it is important to note that it's not functioning at optimal value in just a moment. So let's move on to the hippocampus, which is also known as the emotion regulation center, and it is behind the prefrontal cortex, a little deeper into our brain. Now, when this part of the region when this region of the brain is strong, we are able to manage difficult thoughts and emotions and recall and recognize memories. So for example, when the smell of a perfume reminds you of your grandmother, that is likely your hippocampus at work. Now, in contrast, individuals who have experienced traumatic stress may experience vivid memories or persistent thoughts that are reminiscent of a trauma they experienced. So as opposed to it feeling like a memory, it feels very real, and that they are more so in that memory, so to speak, versus it just thinking, or it coming across as something of the past. And so they may have a difficult time distinguishing between a memory and a current threat. And now finally, the amygdala, which sits a little lower in the brain. The amygdala is known as the fear center. It responds to stress and anxiety and coordinates a behavioral response that helps to ensure survival. And this is also known as the fight, flight, or freeze response. I'm sure lots of you are familiar with that sort of saying. And so, for example, imagine you're walking down a hiking trail and suddenly you see a snake. With lightning speed, your amygdala reacts to that snake before you even consciously notice it, and you're running away, right? So your amygdala is what is helping you to react quickly when there is a threat in the forest or on that hiking trail. However, it can be a problem for someone who has experienced trauma, because in the traumatized brain, the amygdala is on high alert, which often leads to inappropriate or erratic behavior, as the brain is unable to access the prefrontal cortex and apply logic to the situation. So this is when we come back full circle to what I had mentioned earlier. If our thinking center is not functioning at optimal value, we can't apply logic to certain situations that we are in if we're a person who has experienced trauma. So here I'd like to give a specific trigger warning. I'm going to share an example about abuse, okay? And this is going to relate back to what we were talking about earlier with the example of the smell of a perfume. So if I was a person who had experienced assault at the hands of my grandmother as a child, and you fast forward 30, 40 years later, and I smell that same scent that of the perfume that my grandmother used to wear, but let's say at this point I'm sitting in your clinic, or you're receiving SSP services at your program, and I suddenly am responding to the person that's sitting across from me that smells like my grandmother, and my behaviors, because in my mind I have flashed back to what is technically a memory. However, it feels very vivid for me since I've experienced trauma, and now I'm reacting potentially aggressively. So maybe I'm having a fight response to that smell. Some other folks might have a flight response. So I might just quickly exit from receiving services or from sitting in your agency. And so this is how the neurobiology portion of understanding trauma can really manifest in the folks that we work with. So now I'm going to move on to the A in neuroscience. We're actually going to skip the E, epigenetics, for just a moment. So A, adverse childhood experiences. Next slide, please. So the original ACE study was conducted by Kaiser Permanente in partnership with the CDC from 95 to 97, and over 17,000 people receiving physical exams completed confidential surveys regarding their childhood experiences and current health status and behaviors. Now, the questions, or those surveys that they had completed, related to the 3 types of ACEs that you're seeing at the top of your screen. So they were questions that related to abuse, neglect, and household dysfunction. And what they learned was that the greater the exposure to these adverse childhood experiences, the greater the risk for negative health outcomes. So childhood experiences, both positive and negative, have a tremendous impact on future violence victimization and perpetration, as well as lifelong health and opportunity. And so you can see that relationship at the bottom with the icons. Just as you see the ACEs increase, the risk is increasing. And so we understand that ACEs are essentially, that is what childhood trauma looks like from a data perspective. This is how we collect information on childhood trauma. And so next slide, please. So this is where we kind of combine the concept or ACEs with epigenetics. So if you look at this diagram, right, this is a pyramid diagram, you'll see adverse childhood experiences is the dark green. It's the third rung up in the diagram. So when we first conducted this ACEs study, what you see as far as the triangle goes from ACEs and up was what they had developed as the conceptual framework for ACEs, right? So they understood that if you experience childhood trauma, it's likely going to disrupt the way that you are developing, your brain is developing, and you can kind of just track your way on up, ultimately leading to potential early death. Now, as research, again, has continued to be conducted over the years, this concept of epigenetics was introduced to our understanding of trauma and adverse childhood experiences specifically. And so epigenetics is what you are seeing reflected in those two lower rungs beneath adverse childhood experiences on this pyramid. And so we have things such as social conditions, local context, as well as historical trauma that are able to influence and affect experiences that a child has. So a really easy example, we are, based in the United States, historically in this country, right? Slavery is a huge part of the history of this country, particularly for Black folks. So if we are to take into consideration somebody who, is born African American, can't control what race we are born into, right? So there is a certain level of, in our genetic code, there's a certain level of trauma as a result of, an African American or Black person's ancestors being enslaved that they are born with. So what epigenetics really did was introduce to our understanding of trauma the fact that before a person is even conceived, there is a weight of trauma that they could be carrying with them. And so that is where we see epigenetics and adverse childhood experiences sort of coalesce. Next slide, please. So finally, the R in resilience. Resilience is also known as protective factors. There's really no single set of accepted components of resilience. There are many, many, many in the research that we were conducting around trauma. What I have here is just some examples of components of resilience that are relevant oftentimes to the folks that we're working with. So do they have a good social support system? Do they have role models in their life? Do they have any sort of training or vocational work? And resilience is really like the hopeful part of our understanding of trauma and of neuroscience. It's the part that could mitigate and does mitigate some of the effects that we see with adverse childhood experiences or with the negative side of epigenetics. And so this is, I always jokingly say, this is the beam of light. And so the idea being that if we build resilience in our clients, if we create environments in which resilience is a part of the care that we are providing and the work we are doing with our clients, even if they have experienced trauma, they will be more well equipped to be able to work through it and to cope with it in a healthy way. Next slide, please. So moving away from neuroscience, just the last sort of theme or concept I think is really important to keep in mind when we are talking about both people who use drugs, people living with HIV or hepatitis, and that's intersectionality. Intersectionality, as someone had eloquently put it when I presented in in the past, is that things relate to other things. And so intersectionality is just a term that we can use to acknowledge the interconnected nature of social categories, right? So race, class, gender, etc. You see some of the examples on the slide right now as they apply to a given group or an individual. And so this is acknowledging that the folks that we work with are not monoliths. So we cannot look at a client's gender or at a client's race solely. We have to also understand their ethnicity, their gender, their class, etc. Identities all coalesce to inform the way that they experience systems of oppression, whether it's the healthcare system, whether it's the justice system, so on and so forth. Next slide, please. Thanks. I'll hand it over to you, Virgil.
All righty. Thank you, Mahalit. So, and wanting to provide a trigger warning for this section as well. If any of the data that is going to be presented in this section dealing with trauma and drug use is triggering for folks, I strongly encourage you to step away or do whatever you need to do to really manage yourself in that moment. So looking at trauma and drug use. So looking at the data around some of the data around trauma and drug use, we can see that there's a very strong link between trauma, its impact, and habits of substance misuse, right? So women, data shows, are exposed to traumatic life events at an increase are exposed to a traumatic life events and show an increased risk for alcohol use disorders. Research shows that 80% of Vietnam veterans seeking PTSD treatment have alcohol use disorders. Men and women who report sexual abuse, have higher rates of alcohol and substance use disorders, and adolescents with PTSD are as close to 9 times more likely to develop substance use disorders, right? So really a good way to help us understand and frame the impact or the intersection of trauma and drug use is using the self-medicating theory, really, which was put forth by Dr. Kansian in 1985. And really this helps us to see and understand that a number of individuals who are impacted by that intersection of trauma and drug misuse are doing so in an attempt to really manage the internal stressors that could be related to their mental and emotional health. So a bit earlier, Mahalit did discuss the importance or the impact of adverse childhood experiences. So looking at the data about the impact of childhood trauma and substance use disorders, it really, once again, reinforces that link and shows that the impact that this could have on children and later on in their life, adults, as they continue. The data on this slide comes from research that was conducted in 2018, and the research compared 2 groups. The first group were 112 individuals who were in treatment for substance use disorder, while the second group were individuals with mild to moderate mental health disorders. And so when they really crunched the numbers, they saw that more individuals from the substance use disorder group had higher instances of emotional, physical, and sexual abuse that took place during their childhood. In addition to that, they also analyzed differences between gender amongst those with substance use disorders, and they found that women were more likely to report mild to severe emotional, physical, and sexual abuse. And I think this also highlights the differences between men and women and the impacts of trauma, but also the need for trauma-informed care that is gender specific. Okay, next I wanted to dive into trauma, grief, and overdose, and the intersection of those things. And once again, giving a heads up, a trigger warning for those who may be triggered by the data that is presented in this section. So the portion I want to also start off by saying that the two slides, this slide as well as that follows, I want to give a big thank you to the Massachusetts Department of Public Health for providing information that is listed in these slides, and that is also one of the resources that will be listed on the resource slide later in the webinar. But when looking at the intersection of trauma, grief, and overdose, there are two domains, two primary domains of potential trauma for staff of harm reduction programs and syringe exchange programs that are related to overdose. So the first is personal relationship and loss. So operators of harm reduction programs, specifically, especially outreach workers, when really managing staff, should be sensitive to the impact of vicarious trauma, right? Additionally, programs should be mindful of any feeling of responsibility or failure that staff may take on in the course of building those relationships with program participants. So this is something really to keep in mind, like I said, for outreach workers who are oftentimes on the front lines, building those relationships and providing services to participants of the program. The second thing that should be considered is collective trauma of loss in the larger overdose epidemic. Now, this is really important, especially within the context of COVID-19, when staff members may experience the loss of loved ones from overdose or the coronavirus. The impact of one or both in experiencing loss to those public health issues could lead to compassion fatigue and among staff. So those are things to really be mindful of when looking at the collective trauma of loss in the larger overdose epidemic. So let's now look at 5 core actions, 5 things that you can do to respond to an overdose, things that should be promoted within harm reduction programs and health departments when working with staff that are on the front lines. So those 5 things are safety, calm, connectedness, hope, and self-efficacy. So with safety, we want to ensure that there's a safe space and basic needs. Really assess the coping mechanisms of staff members. How are you coping with the vicarious trauma, with the barriers presented and the struggles presented to your target population? What are some of your coping mechanisms? Communicate your interest in their safety. Really, that's something that can be taken for granted or just assumed. But really communicating to staff that their safety is also a priority. Calm. So project personal calm, really be able to listen to participants and staff members and let them set their pace. Normalize intense emotional thoughts and the transparency of those, and also suggesting coping mechanisms or alternative ways of coping that could be healthier. Connectedness. So we want to really encourage connection with peers and supports that have a similar experience. We want to make sure to be sincere in your connection, give individuals the permission to take the space that they need, an opportunity to really take a step back and really do an assessment of self before moving forward and continuing to engage in the work. Hope, a very, very big core factor of the 5. Express hopefulness in practical terms, really reinforce the gains, the strengths of the individual, and reaffirm that recovery from stress is possible. It doesn't have to be a chronic thing. There are ways of alleviating stress and really maintaining and sustaining hope in the nature of the work that harm reduction programs do. Self-efficacy. So self-efficacy, we really want to engage the person in decisions, next steps, action plans, encourage small achievable steps. So this work, it's very easily to become overwhelmed. So really taking things day by day and step by step to ensure that staff is not overwhelmed, which could obviously lead to things like burnout. And avoid being overly critical, right? Or critical in a way that really diminishes hope and a feeling of calm and connectedness for participants and staff members of the program. And for that, I will hand it now back over to Mahalad, who will be discussing trauma-informed principles and the importance of resilience.
Thank you, Virgil. All right. So trauma-informed principles and resilience. So we're going to be talking about you can go to the next slide, please, Virgil. We're going to be talking about the Substance Abuse and Mental Health Services Administration's 6 principles of trauma-informed approaches. And a trauma-informed approach reflects adherence to 6 key principles, these 6 key principles, rather than a prescribed set of practices or procedures. And these principles may be generalizable across multiple types of settings, although, terminology and application may be setting or sector specific. So take it as you may. So this is an overview of the 6 principles, but we're going to talk through each of them briefly. So let's go ahead and jump into physical and emotional safety. Next slide, please. In order to create and maintain safety for trauma survivors, an agency or a program must establish a positive and safe environment that is free of judgment and shame. And this really takes intentional work because our culture consistently communicates very strong messages about the shamefulness of using drugs, the shamefulness of HIV status, gender identity, so on and so forth. Additionally, survivors of trauma need to be understood as whole people and as more than just their traumatic experiences. So a few examples of how to do this: avoid shaming language, use LGBTQ inclusive language and images in your clinic or agency spaces, and use clear and easy signage as far as how to get into and out of a room. Also, when speaking with your clients, be mindful of tone, voice, volume, and body language. Some of the things we take for granted, but also worth noting and pointing out that they are specifically important. Next slide, please. The next principle is around collaboration and mutuality. So survivors of trauma benefit from an approach that is truly collaborative, in which there is partnering and leveling of power differences. Trauma survivors have most likely experienced a loss of power related to their traumas. And so an approach that seeks to equalize power differences can restore agency to that survivor and help them take ownership of their own learning experience, of their clinical experience, of their health experience, so on and so forth. So allowing people that are using drugs, people living with HIV, hepatitis, etc., to collaborate with their providers in their own health experience, and that shared decision making. So making a client aware that they're in charge of their own body and their own medical care, that they can be a part of the development of their treatment plan, let's say, and really just believing that this, believing in making this structure, and also ensuring that the supports are in place to make it happen. So not just lip service, but making it an actual part of your procedure when developing a treatment plan, that it is done in partnership with the client. Next slide, please. Trustworthiness and transparency. These are important to a trauma-informed approach because trauma survivors should have access to information that pertains to them, and a say in decisions, that will affect them. And that really, again, relates back to the collaboration and mutuality principles. As you'll see, these principles are not really mutually exclusive. They all are sort of interconnected in ways. So when showing transparency, it builds trust, and this also reinforces safety. Aim to develop an authentic and judgment-free relationship with your clients who are using drugs. Oftentimes, survivors of trauma have experienced a breach of trust of some kind related to the trauma that they experienced. So working to restore trust with survivors by being transparent with them is really important. So people who use drugs or staff, whoever it may be, as we're trying to do today, should receive warnings when there may be content or activities that could be triggering. And next slide, please. Moving along to our fourth principle, empowerment, voice, and choice. People who have experienced trauma benefit when we can correct power imbalances. Trauma temporarily takes away any power, voice, and choice, and a trauma-informed approach attempts to restore those things. So the approach should be building on strengths instead of focusing on problems or being needs-based, and that's really key when working with survivors of trauma. We're focusing more and building around a strengths-based approach versus a needs-based approach. And then next slide, please, our fifth principle, which is peer support. And I think that this is one that a lot of folks are probably familiar with. We are not a stranger to peer support groups in the world of HIV, hepatitis, and drug use. So this one is probably a little bit of a duh, but still very important to point out. Peer support is key to establishing safety and hope, really building trust, enhancing collaboration, and an environment where folks feel familiar and that unique level of connection that is brought upon with shared experiences. So utilizing stories and lived experience to promote recovery and healing is of the utmost importance. And then moving along, next slide, please, to our sixth and final principle: culture, gender, and historical issues. So this can look like asking for pronouns, actually using the correct pronouns when someone has shared their pronouns with you, acknowledging that someone has a history with trauma if they have disclosed that to you. So another example of this might look like, we don't have time to get into this, but something that is known against amongst people, Black folks historically from this country, okay, are the level of medical mistrusts that relates in the community. We can look back on the Tuskegee syphilis trials. We can look back on the story of Henrietta Lacks and her cells that were taken from her without her knowledge and used for science and research. And so acknowledging these sorts of things and how that level of distrust has been generationally passed along and is still present to this day, it's important to again, create that trauma-informed environment. I believe that is it for me. Next slide, please, Virgil. Yes, passing it over to Tim. Thank you.
Okay, thank you. Can you all hear me?
Yes.
Great. So I'm really glad to be here today and joining you all. Virgil, Mahalit, thank you for really establishing that framework and segueing into some of the information I'd like to present. I'm going to echo the trigger warning, and just if there are times during this presentation where you feel like you need to step out and ground or collect yourself, certainly invite you to do that. I will introduce myself. I'm Tim Bandel. I work in a federally qualified health center here in Asheville, North Carolina. We've got a few health centers I work in, one particularly. In addition to primary care, we provide some behavioral health support, which includes clinical and peer support, pharmacy, and some case management. We provide medication-assisted treatment for folks that have opiate addiction, and also actively and aggressively treat hepatitis C in our patients who are seeking treatment. And so we work with a number of patients who are actively engaging in drug use and struggle with that in many forms and fashions, many of whom utilize syringe service programs here in Asheville and other services that promote harm reduction. So I just wanted to, Virgil, is there a slide with sort of a Excel graph with numbers on it after this one? Could you go forward one slide?
I believe so. Yes.
Okay, yeah. So I wanted to look at this one first, and then we can go back. So I just wanted to put a snapshot out of some of the patients that we work with, we serve here in our clinic. Since we have a registry specifically for the patients that we do medication-assisted treatment with who have opiate use disorder, it was easy for me to be able to pull that information specifically from that subset of our population of patients. So again, this is just a window seeing how some of the things we've talked about up until this point actually manifest into the people showing up at our clinic. And so this is about 140 patients that this information was gathered from between men and women, and having an average ACE score of around 4.8. This is using the ACE that we do universally for our new patients. And I just wanted to, highlight some of the numbers here and just how much of a reality it is that the folks that we see here have experienced various traumatic events in their lifetime, both in adulthood and, in this case, in their childhood. And then to the right, there's just the BRIFIS, the Behavioral Risk Factor Surveillance System for North Carolina. And those are some of the numbers from a statewide level as far as the ACE score. And so, as you can see, there's a significant gap, disparity there. And as far as how many folks are showing up here compared to the, state population with these high ACE scores. And my sense is that some of these scores in the reporting is actually lower than in reality, oftentimes because of some of the shame and stigma that can come with reporting. So I specifically pointed out 2 of the ACEs as well, just given the increased risk for folks that have experienced sexual trauma as it relates to intimate partner violence, suicide risk, and sexual victimization in adulthood, particularly with females. And just noting that high number. And then also the number of people that had reported feeling unloved and seeing that, the emotional neglect. So oftentimes there's this question that we ask when it comes to adverse child events, rather than what's wrong with you, as far as someone presenting now, shifting to what happened to you. And it's just highlighting that it's not just what happens to people, but what doesn't happen and what's not there growing up. And so the high number of folks that have a sense of overall just feeling unloved throughout their childhood and what that does over time. So instead of going forward, Virgil, if you can just go back actually to that slide. And so these are just some quotes here that I put out that more or less just highlight and reinforce some of the things that have already been shared in the presentation as far as what we know about trauma and its role in developing in the brain and how that leads to many adverse health outcomes over time. But I really just wanted to highlight some of the things that I feel like for us as providers, and then also when talking with folks about trauma and addiction in the intersection, how it can help conceptualize, not with just numbers and what we know as far as factual, but how this really plays out over time. And so Dr. Vincent Felitti, one of the co-authors of the original ACE study, having a couple quotes here as far as the the role that ACEs play in addiction. And as far as you can determine the time, really the major factor is these experiences not healing over time. And so again, that's highlighting not just that experiences happen, but also whether or not they heal over time. And resilience certainly plays a role in that healing process, both in childhood and then of course in adulthood, which is what we're speaking to a lot now as we're seeing folks. And then this idea that it's just really hard to get enough of something that almost works. And so really reinforcing this idea that people are trying to make it work. And the reality is that, again, it's just not going to often happen. And it's an effort of people to really try to get something, but often just falling short, and really helping to frame it that way as well. Gabor Mate, who some people may be familiar with, has done a lot of work in Vancouver, Canada, and I think he really has many quotes, many notions that conceptualize trauma and addiction in the intersection. But one way I think that he conceptualizes really well is this idea of just having a lack of experiences that are enhancing the endorphins in our brains, and the fewer that we have, the greater the need over time. And so that really, again, speaks to this process to make it work, to really enhance those endorphins, which oftentimes can be done so well through drug use, but again, at such a great cost oftentimes. And this quote here, the first time I did heroin, she said to me, it felt like a warm, soft hug. And so just this idea, again, that oftentimes there's this emotional void. And I think that speaks again to that statistic before, as far as feeling unloved, and that the intersection of that over time, especially with substance use and the role that that plays. And then lastly, just this idea that injuries, especially psycho-emotional ones, sometimes can heal with time, especially depending on how much resiliency we have available to us and within us. But oftentimes they do require medicine over time. And so now we're really looking to find more resilience and get that medicine on board. Next slide, please. Okay, and then just a few other points, specifically speaking to resilience. It really is, in a lot of ways, both preventative and curative. And I think one thing that we're trying to do oftentimes with our patients, with ourselves, we're really trying to cultivate resilience. And I think one way of conceptualizing that is this quote from Jon Kabat-Zinn, you cannot stop the waves, but you can learn to surf. And so in essence, a lot of folks have not really learned to surf these waves. And what we're trying to do now is create conditions where they can feel comfortable to begin to learn to surf these waves of emotion, of psychological distress, so that they can continue to lead their lives and not feel like they have to go under the water to avoid the waves altogether, because oftentimes that seems like what people have been trying to do that are using drugs in an effort to manage the waves instead of surfing, oftentimes going under the water. And sometimes it works, but eventually it becomes really tiresome and ineffective, and sometimes, in worst case scenario, deadly. So in all that time to avoid the waves, eventually get slammed by them. And when you do come back up, the bigger the wave, the deeper you go. And sometimes you just get swept up anyway. And so really, we're just trying to think of it as that way, as giving people tools and conceptualize it as not stopping the waves necessarily, but learning to surf. And so just because people have high ACE scores doesn't necessarily mean they don't have resilience. And so in some ways, people can have traumatic things happen, yet also have growth and resilience as a part of that. And so also being able to identify that in folks, the resilience that already is there and that may have stemmed from the things that people have experienced in their lifetime. And there's also this notion that we try to really keep in mind that, you know, unresolved traumas lead to reactivation. And so a lot of what we're doing too is, as was discussed in the previous slides, trying to minimize reactivation of these traumas that are residual and lingering, and to be able to not let them metastasize, so to say, as cancer might. And then in doing that, we can really help people respond to new traumas, and then over time, expand their capacity to resolve old ones. Next slide, please. So I just wanted to share this visual here, and giving that credit to EMDR Consulting in their training manual, from which this is coming from, just to sort of conceptualize the evolution of maladaptive core beliefs, and then adaptive one, of course. A moment ago, I mentioned this idea that there's been a shift from, you know, asking what's wrong with you to what happened to you, to really explore that and allow time and space for people to talk about that and start to, you know, promote an atmosphere where healing can take place. In addition to that, really, there's this idea that we can further expand on that in asking, well, what does this mean to you? And what does this say about you as a person? And, you know, my role in particular, trying to help people expand on that and identify that, because therein lies oftentimes the issue, not necessarily what did just happen, but also what does this mean? What narrative do I have that comes from this? And so not just that the storm happened, but what did the storm leave behind in its wake that continues to have an impact on my day-to-day life? So again, there's a lot of old stuff. So if you look on the left-hand side, this is sort of negative maladaptive beliefs that can stem from a very early age, oftentimes before people really have a working memory. A lot of this is implicit or pre-verbal, oftentimes. And some of this stuff has been around for a while, and resilience really hasn't entered the picture on any consistent level, oftentimes until people are older, maybe even out of the home, in different relationships, different settings, and sometimes for the first time in the context of the relationships they have with us, you know, in the service sort of provision. So really we're trying to enhance that good stuff by what we can do, really abiding by those, you know, 6 tenets or principles that Mahalat was speaking to in trauma-informed approaches, and really enhancing that while creating the space and time for people to address old traumas that may be unresolved through maybe even deeper psychotherapy and treatments. Again, this idea of not letting traumas metastasize. So we can certainly play a role in doing that. Next slide, please. So I just am listing out here some of the things that our particular clinic, our organization has really tried to do on a daily basis with our patients in this setting to cultivate, promote resilience, and then uncover it. Again, sometimes resilience is there, yet the space hasn't been created for people to actually see that in themselves, or other people recognize it in them. And so uncovering oftentimes that which is already there. And then of course, working to cultivate and promote even more resilience. So education, just some of the things that we're doing now, having these same conversations in a way that makes sense and is practical with our patients every day in the clinic, and with our staff, with each other, because at the end of the day, we all, as humans, are susceptible as well to trauma and some of the stressful events that life can bring. And so just really being able to educate ourselves and people that are family members of our patients as well, parents, siblings, partners, to help really connect those dots. Reframing stress, really there's this notion, and there's been research around it, of, eustress versus distress, and trying to help just the idea of reframing stress as not necessarily something that has to be bad, and something that can really promote resilience, promote growth, referring back to post-traumatic growth, and then distress and what that can look like. So thinking about a tree and how you might actually chop a little bit at a tree, but if you chop just so much, it actually might start to produce fruit in an effort to promote its own resilience under that stress. But chopping too much can actually lead to it withering and starting to die. And so really trying to reframe stress as well. So that helps people maybe have a different attitude and outlook on stress and how they might approach it and manage it. Universal ACE screening, of course, is something that we've been doing for about 2 years now, maybe a little more. And so we're able to track that, particularly with our folks that are on a registry, and get a sense of where folks are at, and it allows to have conversations about ACEs and what that is, what that means, resilience, and so we've been doing that, which has been really helpful for both us and, we believe, the patients, in creating that time and space to have those conversations. Trauma and toxic stress and drug use, and again, just really connecting the dots like we've been doing during this presentation, the intersection between trauma and drug use. And so that in of itself, it can be really powerful for individuals in the throes of substance use, for their family members who just can't seem to understand why people are behaving the way they are, for our staff, and for when we struggle at times, just to really connect the dots. And that can really shift the needle in terms of people being open to making some type of change in a different direction, or building a little bit of trust and rapport. Another thing that we've been doing, not as much lately, but trying to get back into, is group visits for folks that are doing medication-assisted treatment for opiate addiction, hepatitis C treatment, diabetes. And again, this is just one way that really pulls in a lot of opportunity for people to connect and relate, and normalize and validate their experiences outside of just them in the room with one provider who, as empathetic and as trauma informed as they may be, just may not really be relatable at times. And so it is a space where it creates optional disclosure, mutual support, especially as it relates to grief too at times. So we've had a number of folks that have mutual friends that have overdosed and died, and so being able to have that space where they can grieve together and work to heal together. Also the sense of being on a team and having that collaboration. Language is certainly one of the things that we've been more aware of, and trying to promote how we use it, how we are thinking about it. And so to the right here, there's this diagram, and I credit the North Carolina Department of Health and Human Services for that, which we've posted around our clinic for, it's been over a year now. And it's just interesting to see how this creates conversations both among staff and then with patients about language and its power, and how it can certainly hurt and then reinforce maladaptive beliefs or old traumas, bring those up. And so I'm not going to go through that visual, but if you can, maybe you can see it. Certainly I'm happy to share it with anyone who would like a copy of that. But again, it's just particularly showing some examples how words have been used over time in the setting of substance use and addiction, and how we can shift those words and the reasoning behind that too. So we can give some good explanation. And the people that have mentioned it the most, oftentimes patients, and really catching them themselves and how they're using language about themselves and their peers, which has been really interesting. So it does create time and space for people to really reflect on the language they use about their own selves, and not just, the providers, they're, professionals. Choice, really, speaking to that idea of empowerment, voice, and choice, and one of the 6 principles, we really promote choice in treatment planning, and really this idea of being able to say no, and how powerful that can really be. So whether it's about how you want to take your medication, what medications, what do you want to engage in as far as a service outside of here, who do you want to be in this visit today? So there's just so many options that we can really promote to create opportunities where people can say no, or just have that choice, because oftentimes people that have had trauma in their childhood have not felt like they've had choice, have really been unable to use their voice in that manner. And so those are small moments, but can be very powerful, especially if they're consistent. Peer support is something, as I mentioned, we provide. We have 3 peer support specialists, one who's here at this clinic all the time, and oftentimes seeing many of our patients, particularly many of the patients during medication-assisted treatment. And so that really creates a sense of being able to have an advocate, again, normalizing, and it shifts the power dynamic oftentimes. It's not uncommon for our peer support specialist to be in the room with the patient and the medical provider, to just be that bridge if needed, create a sense of feeling a little bit safer, a little bit more comfortable. And so peer support is something we really have been able to utilize, and is so integral to the services we provide, particularly for our folks that are using substances. Harm reduction. I would imagine most people in this presentation right now that are listening in are familiar with that and what that can look like, and how harm reduction isn't just a practice, but really a philosophy. And so we certainly embrace that philosophy on many levels, and not just with someone's substance use, but really any behavior, whether it's what they want to do about their housing or the relationships that they're in. And so really just promoting that continuum of being human-centered and acknowledging that change is on a continuum. And even though people may be engaging in behaviors that certainly bring risks, there's ways that they can mitigate that. And in doing so, they have options to make choices about their health and wellness. And so it really, I think, is a humanistical way of looking at things. And, us as people that are working with these individuals also struggle with change as well. And we, practice harm reduction in our own lives. And so in a lot of ways, it's no different, whether it's diet, my access to, exercise and what I want to do about that, relationships, even the time we spend on our phone. So again, we really embrace that and find that it's very empowering and sets people up for choice and success, even in the setting of active substance use, of course. Environment. And we spoke to that. That was one of the tenets, at least creating, physical and emotional safety. And certainly we try to do that, create a welcoming environment. And again, giving people choice in their treatment planning, even really just giving people options as well, as far as, when they want to, follow up and how that can look. So we really try not to be very stringent and be very flexible. But again, as far as the environment goes, we really try to keep an environment where we can be open with people and very aware of, scents, like smells and odors and how triggering those can be. And it's something that can be tough depending on what your situation is and the environment you have. So, we try to, as best we can, create our particular clinic to be one that takes into consideration so many triggering factors for folks who have experienced trauma. And then basic needs is certainly something that is very important. We serve a lot of folks that are unhoused in the community, transient as far as their housing situation goes. Staying in tents along the river or in shelters or doubled up. And so really just addressing people's basic needs and really being aware of that and how important that can be. As far as giving people an exam room to sleep in for a few hours, even if they have, been using substances and are maybe crashing right now. So creating that safe space to meet that need in that moment. Food, security, clothing. It's not uncommon for a lot of our patients to use this clinic as a place of safety and refuge. And so really being able to send a message that this is a place where you can do that. Of course, there are limits and boundaries that we have to put around that, but we try to do the best we can. And then more on a skills-based level, as far as just being able to offer really practical tools that help with managing trauma, managing PTSD, managing, emotional stress, dysregulation. So grounding skills, things that, can really help people feel like a sense of self-efficacy in my ability to manage my emotions when things don't feel okay. I do feel unsafe, and manage my space too to secure it safely. I don't know if anyone's familiar with the community resiliency model, or CRM there, CREM for short. And so that's something that we've been able to have our staff trained in. Not currently, so we probably need to update the folks that know it, but we have had sort of universal CREM training for clinic staff to really help build skills that they can use themselves. But of course, these are transferable and can be taught very easily to other folks as far as how to regulate the nervous system through simple acts, oftentimes that don't require a lot of mental, energy to really have to do this, but very practical and speak to the language of sensation, which the nervous system can respond very well to.
I'm so sorry to cut you off there, Tim. But just to ensure that we give time for our final speaker, I'll ask if it's okay with you if we can move forward.
Yeah. The last three there are just three things that particularly our behavioral health clinicians have been trained in to provide as far as really trauma treatment. And so, yeah, I appreciate the opportunity. And yes, definitely let's move on.
Thank you, Tim. All right. And Margaret, I'll pass it over to you.
Thanks so much, Virgil. Good afternoon, everyone. And you can go ahead to the next slide, Virgil. My name is Margaret Bordeaux, and I am a justice-involved overdose prevention specialist. And I came into this work starting at a very on-the-ground level, providing instruction of a opioid overdose prevention education course at the New Hanover County Jail. From that course and the good folks who were participating in that, we created a second next level course, and it was called A Good Samaritan, where we taught more harm reduction skills, and we really went over the principles. In the Good Samaritan course and also the opioid overdose education course, the best part of that was facilitating some of the conversations that would happen between myself, the other instructor, but more importantly, the folks who were residing in the jail, right? And they would always come into the space very open and honest, and we made sure to be active listeners and really encouraging folks to be open, realizing that they were in a space, right? And not just a physical space that a detention center may be, but also they may be in a space mentally, some realizations that happen when folks are incarcerated. So we would talk about things, and my experience from that was able to help me with the work that I'm currently doing, and that's providing technical assistance to other programs who are doing this work. And so I work a lot with some of the programmatic staff and the direct service staff who are doing various programs. And from my experiences and the things they share with me, we've all found some common overlapping issues among people who use drugs who are impacted by the carceral system. And that's housing insecurity, that's family dysfunction, unmanaged behavioral health diagnosis, and time and time and time again, histories of trauma. Next slide, Virgil. What I've heard Helen, Timothy, and Virgil all refer to like some of the intersections. Let me say that jails, prisons, and detention centers will serve as the junction, right? This is a place, and these are places where that substance use in chaos, and then some of those adverse childhood experiences and a lot of trauma is something that many folks in correctional spaces have all at once. But incarceration in itself can be traumatizing. When folks are detained, they often have a lack of support from their family, contact from their family, and visits. And we need to be thinking about this right now in the wake of COVID and its response. Visits have been suspended at many correctional spaces. So what before was just a lag, or sometimes folks not, having those relationships with their family, right now is suspended for all folks who are incarcerated. So I ask everybody to think about this during these times of COVID and how that is impacting each and every one of us. Also, incarceration, things that people will talk about a lot of times were guilt and shame, right? And some of those things they were carrying with them from their past traumatic experiences. But in incarceration, you're exposed to violence. That could be self-harm, that could be inmate and guard, and that could be self-inflicted. And it's not always physical violence. We found that like verbal abuse is the one thing that many participants of these jail-based outreach programs always think about a lot. Derogatory language is used a lot in correctional spaces, and again, can be very triggering for already having a history of trauma. Um, for people who use drugs, any period of incarceration is it could be forced abstinence if it was not their choice to suspend their use activity, and so some folks are sent into withdrawal, and this could have physical and emotional distress on folks again in this traumatizing space. So having all of these things going on, and many folks who use drugs and folks who are just as involved, they have other chronic illnesses. You will see that with like Hep C, HIV, and sometimes some mental illnesses as well. So all of these things are happening, and the space that incarceration in, sometimes loud. Again, you don't have as much privacy as you would have before. You will see perpetrators. It's not uncommon for perpetrators and victims to all be in the same spaces within jails and detention centers. So this is a brewing pot for flashbacks and triggers, and these are things that were always shared with me. Next slide, Virgil. In jails, prisons, and detention centers, you may not have all of the opportunities that Timothy shared about care that can be provided in a FQHC, or some of the trauma-informed in SSPs and other harm reduction or community-based spaces, because we do have to recognize that jails are challenged to do a lot of work. Jails, prisons, and detention centers, and public safety is one of them. But in recent times and how things are going with the justice involvement of people who use, we've also dually asked correctional systems to be help communities maintain some public health. This isn't something that they were doing before. Again, most of their practices are around the safety of the other folks who are residing there and the people who work there. So those things are important, but it's still opportunities for jails, prisons, and detention centers to become trauma-informed institutions. very simple things. Quite possibly, it's just understanding that those individuals in those spaces are affected by, and recognizing and trying to minimize some of the things that can occur between the staff and the folks who are residing there, and sometimes between folks who are residing. Again, lots of people from many different backgrounds and many different experiences and histories of trauma, all in those settings together. One thing that I always was very careful to do in my outreach was to acknowledge those power imbalances. I wasn't a correctional officer, I wasn't a detention officer, I was a volunteer, but there was still some power imbalance there, and I wanted to make sure that it was noted. The fact that I was able to come into the New Hanover County Jail and leave on my own design was a power imbalance in itself. So I'm very careful to share that information with folks who are doing and reaching outreach services in jails. Also, to avoid re-traumatization, uh, there was a lot of open dialogues in the courses that I would teach in that space, but never was anyone obligated to share or to be re-traumatized. We gave out trigger warnings at almost every space within the course, and always making sure to read the room and check folks out and see who's comfortable, and not making folks feel bad if sometimes the conversation was going in a direction that they didn't feel comfortable with. They could leave the class and come back when it was ready, when they were ready. Some other things that I feel like prisons and jails can do, and folks who are working in those spaces, is some trauma-specific treatment and interventions, and that could be much like the Good Samaritan class. Like I said, in that opioid overdose education class, me and the other instructor really assessed what was going on, what we were actually learning from the folks participating in the class. And we thought we'd take it to a next step to really give folks a better understanding about why they had the feelings that they feel, and some of the internalization that they took, some of that internalized stigma that they had, and understanding that some of the things that they were going through were not unique to them, and that helped them alleviate some of that guilt and shame that they had around their drug use behaviors, specifically their incarceration. But prisons and jails can absolutely do this in-house. There are opportunities to have staff working in these detention centers use other tools that help people build resiliency. They can have active case management that includes collaboration and autonomy. Autonomy is something that's very big to me because I wholeheartedly feel like people can self-govern themselves, and sometimes even when people don't make the best choices, it was their own self-governing that allowed that to happen. So uh, these are things that can happen in correctional settings, but the biggest thing, and I saved it for last because I think this is very important when we're working with folks who have history of trauma, and specifically within correctional spaces, is to use that trauma-informed language. But some extra tiers to that for folks who are incarcerated could be body language and eye contact. Many times they would tell us those were the things that they did not get often from detention officers. They would be referred to by inmate numbers or last names. So I always was very careful to use folks' first names as I learned them, and introduce myself with my first name. But other ways for trauma-informed language is like body language. They would say often when detention officers would come to work with them, or would come, in spaces where they are, they always looked disconnected, like they didn't want to be at work, and like dealing with them were burdensome. A recent training I gave last year to a local county's detention center officers, we talked about some practices that they would take after receiving a presentation that was sort of like the one I'm giving today. And they didn't have to share their responses, and they were confidential, but they did know that I would look at them later. And I draw from that one that was really important. And we were talking about some things they could do to be of assistance for an already active case management program. But one of the officers reported that the one action that he was planning to use when he went back to the jail to work in that space was to ask folks how was their day a little bit more. And it seemed to me extremely important because if folks are in correctional spaces like prisons, jails, and detention centers, a detention officer pretty much knows how that person's day was because they've been with them most of the day. But that doesn't mean you know exactly, how that day was for that person or what they went through that day. So having that detention officer say the one action that he was willing to take in putting more trauma-informed approach into how he delivered services at that jail. It was really heartwarming for me because we realized that it's important to mitigate some of those traumatic experiences by just being very humanizing and caring. Thank you so much, Virgil.
All righty, thank you. So I'm gonna look now to see if I don't believe that anyone has submitted any questions in the chat box as of yet. But to be respectful of folks' time here on the call, what I will suggest is that we can go to the section of the webinar, the slide that has our contact information. And if you would like to jot down my email address, Margaret or Tim's email address, or if you have a question for Mahalad, jotting down our contact information, and we can most certainly be sure to respond to any questions that you have concerning the webinar. In addition to that, we'd like to also remind folks that we do have a resource page that has a list of resources that you can obtain that will better inform you on trauma and its impact on individuals who struggle with substance use disorders or substance misuse, and the intersection of things such as incarceration and gender. So be sure to reach out to me if you would like that list, and I'll be sure to send it right over to you. Would anyone else of the other panelists like to say anything before we wrap things up?
Ms. Mahalad, I just want to thank everyone for joining and look forward to responding to any of your questions via email. But that's all. Thanks, Virgil, and thank you to my fellow panelists as well. Great, really great webinar.
Yeah, likewise.
Yeah, I'd like to say the same, Virgil, and I know that I went really fast towards the end. So if folks have questions or if there were any questions specific to that justice involved piece, feel free to use my email address.
Oh no, you were fine, Margaret, and a thank you again to Tim, Margaret, Mahalad, to all those on the call. They really were very instrumental in helping me coordinate this webinar. So a big thank you to all of those individuals, and a big thank you to all of you who have taken time out of your schedules to join us today on this webinar. We greatly appreciate it. And with that being said, thank you all for your time. And like we said, feel free to reach out to us, given the contact information there. This webinar will be uploaded to our drug user health page. Thank you. And until next time, I hope everyone stays safe moving forward, and have a great day.